Options for managing early onset flexion and extension space tibial femoral instability after calipered kinematically aligned TKA. So option one, you can always observe patients that can cope with mild anterior-posterior flexion space tibial-femoral instability. So this is an example of a 69-year-old gentleman. We retained the PCL in his left knee, and we excised the PCL in his right knee. 15 months status post his left CR implant, as you see here, with retention of PCL. 7 months afterwards, a medial pivot sphere CS implant where we excised the PCL and did not adequately compensate for the increase in the flexion space. Surprisingly, the self-reported Oxford knee score was the same in both knees, so the patient was satisfied, but noticed some instability. If we look at the postoperative alignments, you can see that the hip-knee ankle angle and joint lines are essentially the same on the right and left knee, and so are the slopes. So we probably should have put a little less slope in when we cut the PCL, but we didn't know that at the time. So this patient maintains high function even though he has mild flexion space AP tibia femoral instability from the PCL resection. So let's look at both knees. Remember, the one to the right is missing the PCL. They both flex and extend very nicely, so a consistent range of motion in both knees. Good, nice recovery. But if we look at him sitting in a chair, you can see that he has the ability to sublux that tibia posteriorly because the flexion space is a little loose, and it requires a ground reaction force to do so. So we could have reduced that risk if we had reduced the slope at that time. So that's my message. If you find that your flexion space is too loose, then decrease the slope, and that may give you some compensation. So I think I should have bone grafted, in this case, the posterior 1/3 of the tibia to reduce the posterior slope. And this is an example of a patient that had this different patient, but there's a native slope on the contralateral side, 89 degrees, and then here we actually did a little reverse slope where we bone grafted the posterior third of the tibia after we made our first cut, and this then tightened the flexion gap and gave us a good outcome. Another solution is go back and take 2 millimeters of bone off the distal femur, which unfortunately raises the joint line. You're actually resecting bone to compensate for a flexion space laxity increase, and you can use a 2 millimeter thicker insert. So this is another option. But you got to warn the patient with the additional thickness of the insert that they still might lose some extension. Option 2 is add constraint and revise the femoral and tibial components in patients that have a disabling amount of AP flexion space tibiofemoral laxity. And I think this occurs in the small subset of patients with this maximum increase that can be up to as much as 7 millimeters medial and 7 millimeters lateral and 4 millimeters medial. You can have a huge increase in the flexion space and trapezoidal gap in flexion in some patients, and if you're not aware of it, you can get yourself in trouble. So this is an example of one I actually had back in 2010, and it takes you a while to accumulate a few of these before you start to understand the pathogenesis and why sometimes you get bitten and get yourself in trouble. So this patient had a right calipered KTK with an unintended transection of PCL. We really wanted to keep it, but we didn't. And here you can see we used a little thicker insert than maybe we needed, trying to get a little tightness in the flexion gap. And from the lateral side, the slope looks reasonable, and it's the same as the other side, but maybe we should have put in a little less. And since we didn't have a PS implant available in the hospital, I tried to compensate by using a thicker insert. So this is where you just got to be very careful. If you're going to have the problem of transecting the PCL, you might want to have a PS implant or a CS insert that gives medial stability throughout the motion arc available. So 4 months later, he was happy with the right knee. We did his left knee and noticed the insert's thinner on the left because we kept his PCL, and that went on to do well. So obviously, he was happy with the right knee initially, and 4 months later, he had his left done. Distal femoral angle, proximal tibial angle is the same. 4 years after the right KTK comes in with instability, and he was having some trouble working as a roofer, and so we thought, well, we'll go put a thicker insert in, and when we got in there, we needed more and more, and just put the largest one in we had, and in retrospect, I should have added constraint at that time. But he returned to work. 2 years after inserting the thicker insert on the right, he had a tibial dislocation while roofing, a traumatic event. You can see that the tibia just translated anteriorly. There's not enough stability in the flexion space. It was reduced in the emergency room, and needed a mobilizer just to keep the knee in. And there was no, fortunately, neuromuscular compromise, no damage to the peroneal nerve. So the definitive treatment of the flexion space tibiofemoral instability would have been add constraint and revise the femoral and tibial components. And I should have and probably could have reduced this risk if I had a PS insert and a femoral component back at the index procedure. So this has been a stable thing and he could get back to work. So what did I learn? Convert to a CS or a PS design when the PCL is excised, transected, or detached from the tibia, and always consider the use of more constraint. And the way to reduce this risk is just retain the PCL and protect the PCL at the outset, which minimizes the risk of this flexion space tibiofemoral instability. Option 3 is observe patients that can cope with mild varus valgus extension space tibiofemoral instability. So we're going to move into the extension space now. And here's a patient had just simple bilateral varus knees. He was a work comp patient, and he complained of this mild varus valgus extension instability. And you can see it here. And I think when he stands, you can see that when he puts his weight in medial and shifts the knee lateral, it opens and closes medially. And this generally means that we did not cut the tibial varus valgus plane correctly. And you can see even on this AP view that the lateral side's closed down, the medial side's open. And this probably was not a well-balanced knee in extension. We did not get a stable rectangular extension space with negligible VV laxity. We didn't know to look for this way back years ago. There's a 12, there's a 10. And what caused this? Well, we didn't have instruments back then to correct small deviations in the femoral component from the native joint line. It could have come from the femoral side. We went back and looked at his bone resections. They should have been essentially 6 distal lateral for the 5 distal medial, because he had 2 millimeters of cartilage wear, and we ended up taking off 7. The posterior medial should have been 7 because there's no cartilage wear and there's a millimeter curve of the blade, and it was 9. The distal lateral should have been 7 because there was no cartilage wear, but it was 8, and the posterior lateral should have been 7, but was 9. So we did not do the femur right. And that led to an instability. We would not have this problem in 2019 because we now know to adjust these measurements. We have better instruments now to make these distal and posterior femoral cuts. So then all the problem comes from the tibial side. So if you stand them up, here's weight bearing laterally and medially. It's very hard to see, but you can get a little feeling that there's this opening on the lateral side when his weight is medial. And this is a hard problem. I mean, the best thing to do is use your verification checks and do the femur correctly to begin with, and then you just fine-tune the varus valgus plane on the tibia. Now, here's what happens when you have sort of a disabling varus valgus extension space tibiofemoral instability, and I showed this a little earlier, at least part of this case. She had a patellofemoral replacement. She was having troubles. We then did her total knee. We did not put the tibial component on the right in enough varus. We did not visually inspect the VV laxity with the spacer block and the trial components. She has a large leg, as you see here, so the big soft tissue envelope interferes with your ability with your hands to assess laxity. You're better off looking in and directly visually looking at the displacement between the spacer block and the distal and proximal femoral and tibial cuts and with the components. So we left the limb in 3 degrees of excessive valgus. She didn't like that. The other leg was 177. There's no arthritis. And so once again, you can see a little asymmetry even on the postoperative radiograph or scanogram. That should not be there. And so we did not see this. We needed to show negligible VV laxity and full extension with the trials and with the spacer block. And then at flexion, we only want that lateral side to open 2 to 3 millimeters. In this case, when we went back and revised her, the lateral side opened 5 or 6, which you would have been able to tell if you had checked that before, that there's not enough varus on the original tibial cut. So we go back and we want to confirm whether we did the femoral component correctly or not. This implant was 9 millimeters thick distally and 8 posteriorly. There's the bone resections. There the thickness is 6 distal medial. That's correct. with a millimeter of the kerf and 2 millimeters of cartilage makes 9. Posterior medial was 7, no cartilage wear. Distal lateral was 8, that's correct. Posterior lateral 7. So in 2017-18, we very rarely get those femoral cuts off any more than a half millimeter, much different than back in 2009 with the previous case. So now we have to just revise the tibial component. The femoral component's correct, makes a simple revision, just increase the varus of the tibial component 3 degrees. So we went back in, we used a cone that enabled us to use a short stem in this relatively large woman. We used a 10 millimeter augment laterally and 5 medially, so we got into smaller plastic, giving us room to move if she were to get a little loose later on. That's how she was after the index procedure at 174, and now she's 177.